morning, everyone. It's a pleasure to be here today in this offline conference, finally after a gap of about 2 years. And I think this topic is very important because pitfalls is something where we all tend to make mistakes, and the person who learns from their mistakes are the one who are the smarter ones. So let's look at the role of contrast in orthopedic imaging. And I think this picture taken by my friend, and you can use these filters and how you can make one particular color stand out. So that's exactly what MR contrast does. You have the MR image. By adding a substance, an intravenous injection, you can try to look at the differentiation between different tissues better. What we use is gadolinium. This, because it has unpaired electrons, but it's toxic in its ionic form. So you chelate that with another substance, which then does not make it toxic. And also, we obviously want it to be excreted once it's finished its function of outlining the structures that we want to see. So if we look at the role, I think we can divide it into 3 situations. Why do we give contrast? One, you see something that you would not see if you didn't give contrast. Second, you may see it on plain imaging, but now you see it better. And third is when you want to differentiate different structures or pathologies. So these are the 3 situations. Let's begin with what you can see with contrast, but without it you may be missing. And there's a classic example here, a patient who's come with inability to walk, and this is the plain T2 sagittal images. This almost looks like CSF. Here the CSF looks dirty, but you know the cord is getting compressed, but still you're not very clear what's happening. And when you give contrast, you can clearly see significant meningeal enhancement. There is an epidural abscess due to tuberculosis, and you can see all this enhancement in the cauda equina nerve root. So here, especially something like this, one may miss it if you're not paying careful attention, but when you give contrast, so when somebody who has got paraparesis, there's nothing compressive, no signal in the cord, always remember you should give contrast. Similarly here again, you have edema in the cord, and contrast shows you that tuberculoma, but it also shows you this extensive leptomeningitis, which on the plain scan you would not be able to make out. And you can see a tuberculoma here in the brainstem also. Another example, this was a young child who came with some injury in the school. Someone pushed her against a wall during play. Neck pain, had taken physiotherapy and all, but was not doing well. You have marrow edema only in C6. And when you give contrast, you can see a lot of edema in the epidural soft tissue. So if you look at this epidural enhancement, it was extending all the way from C2 to C6. Very odd for tuberculosis, but we don't know what is happening exactly. And that's when you look at contrast, the dynamic images, you can see there is this focus. These are the blood vessels. But here is a focus which is enhancing as much as a blood vessel almost. And that on CT is an osteoid osteoma. Or another example, in fact, my colleague Aditya did the RF ablation for this. We had this child with typical presentation of osteoid osteoma, severe night pain. And on CT, you had 2 of these lesions like this, very close to each other. Corneal images, you can see this. Now, when you're doing RF ablation, you want to be very precise. You want to know where you are doing the procedure. Which of them is the real osteoid osteoma? Again, dynamic contrast comes to a help. And this is the osteoid osteoma, the one which is lighting up. And the other one is just a small cystic area, which we see often and is not the osteoid osteoma. So this is when contrast helps. A glomus tumor, it's like 1 or 2 millimeter sized lesion, which may be missed on the plain scan sometimes, or it may be so small and subtle you're not sure whether it's really there. You give contrast and it lights up. Similarly, a syrinx. When you see a syrinx, but there is no Chiari malformation, the tonsil position is normal, you should always give contrast. This looks like a regular syrinx, but when you give contrast, you can see this area is enhancing, and this is astrocytoma. So whenever you see syrinx, adult patient, no Chiari malformation, make sure you give contrast. Again, this looks just like a plain syrinx, but on contrast, you can see this is all the enhancing astrocytoma. The second situation where you see something better because you have given contrast and you can differentiate it from other pathologies. For example, when you have a periarticular lesion like this, is it cystic or is it solid? Solid, synovial sarcoma is a possibility. Cystic like this, where it does not enhance, is a ganglion. So if it's not in the typical location or does not look very typical bright on T2, you should always give contrast. Someone cannot afford contrast, ultrasound can be a cheaper way to do the same thing. Something again here, is this Baker's cyst? But does not look, it shows too many septations inside. You want to give contrast, it's enhancing, and this is a synovial sarcoma. So remember, myxomas, synovial sarcomas can look like a bursa or a ganglion. You need to give contrast to differentiate solid from cystic. Again here, is this a ganglion? You give contrast, it's enhancing homogeneously. This is not a ganglion. Tumors, is contrast necessary? Yes, to differentiate solid versus cystic. Edema in tumor, contrast may not differentiate because edema may also enhance. In fact, there are many institutions, especially in UK, who do not give contrast in tumor. But we have found that always adds to the information. For example here, this is surely a soft tissue sarcoma, no doubt about it. But where will you do the biopsy from? So when you give contrast, this is T2, this is contrast. You can see this is all the solid enhancing component and this is the central necrotic area. So you have to do biopsy from the solid area and not from the necrotic component. Lesion here, what is this? On contrast, it's showing homogeneous enhancement. This is round cell tumor. Similar looking lesion on T2. But when you give contrast, it is showing rim enhancement. So this is tuberculous abscess. So again, this differentiation is important. Post-op spine. If something has peripheral enhancement, that's a recurrent disc herniation. While it has homogeneous enhancement, that is epidural fibrosis. Here, for example, you have epidural fibrosis encasing the nerve roots. On plain scan, you may not see much. The last, I think, 2 or 3 slides. MR arthrogram, we don't do it much really nowadays because 3T images can show us better, but you can inject contrast. Peripheral angio, you can give contrast. And the last one, cartilage degenerate, you inject contrast. See, the cartilage where it is degenerated will not take up contrast, will take up more contrast as compared to normal cartilage. We don't really use this too much. Is MR contrast safe? Yes, but it can have allergic reactions, and also we have to be careful of nephrogenic systemic fibrosis. There was a time when we were injecting contrast all the time without bothering about the creat levels. That was many years back. Now we know that in patients with eGFR less than 30 ml, we have to be very we have to be very careful about the contrast that we give in MR also. Thank you very much for your kind attention.